Hi, I'm Stephanie Hertz, Marketing Director here at Warren Forest. I'm sitting in one of the resident lounges that's available to our residents to reserve for activities such as card games or family get-togethers. Today, I have the pleasure of introducing Christina Bergey. Christina is a geriatric assessment nurse with the Riverside Center of Excellence in Aging and Lifelong Health and is a certified wound, ostomy, and continence nurse. Mrs. Bergey earned her Bachelor of Science in Nursing from Shenandoah University in 2008. She's experienced in wound, ostomy, and continence care and has worked in outpatient clinics and acute care settings. She enjoys educating healthcare staff and the community in each of her specialties. Mrs. Bergey is an approved clinical skills instructor for the Wound, Ostomy, and Continence Nurses Society's Wound Treatment Associate Program. She previously taught for the Riverside Health System's Wound Treatment Associate Program. She and her family reside in Suffolk, Virginia. Today, Christina will be sharing best practices for skincare.
Hello and good morning. My name is Christina Bergey, and I am a geriatric assessment nurse for the Center for Excellence in Aging and Lifelong Health with Riverside. I am excited and thrilled to be with you today to share on a subject that I am very passionate about. I've been doing wound care for a long time now, and I'm excited to discuss that with you guys today. If you could please save your questions for the very end, because I do have a lot of material that we will be covering today, and we will be answering those. Even at the end of this video, we're going to take some time to answer those questions and make sure we answer all of them. So thank you so much for joining us today, and we can get started. All right, so to get started today, the title of the presentation is Best Practices for Skincare. Outlined, we can go to the next slide. We will discuss today the anatomy of the skin, the wound healing process and anatomy, the common types of skin damage, which are mechanical, vascular, infectious, chemical, allergic, burns, diabetic foot ulcers. We'll be discussing the signs and symptoms of infection. Also, I am a continence nurse, so I'm going to discuss a little bit about incontinence, products, and daily skincare. To get started today, next slide, I wanted to go over the anatomy of the skin with you. The skin is a complex organ, which is commonly often forgotten about. It is the largest organ of the body. Intact skin is the first line of defense from environmental threats. And we'll be discussing three important layers of the skin, which are the epidermis, the dermis, and the subcutaneous tissue. The epidermis is the thin outer layer of the skin. The dermis is the second layer of the skin. And the subcutaneous tissue, as you see in the graphic, is that very bottom layer, which is the deepest layer. The overall functions of the skin, if we think about the skin, are protection, thermoregulation, communication, metabolism, and sensation. Next slide. So the epidermis, we'll start with that top layer. It actually contains no blood vessels. We call that avascular. It regenerates every 4 to 6 weeks, about every 28 days. The function of the epidermis is it protects the skin from threats. It controls of water loss through the epidermis. That helps to seal in the body's moisture itself. That second layer is called the dermis. That contains a network of blood vessels, nerve endings, sweat and sebaceous glands, which that contains our oil, the oil of our skin, lymphatics, and hair follicles. The overall function of the dermis is the tensile strength, moisture retention, nourishment to skin. So it helps with blood and oxygen. It protects underlying structures, muscles, bones, and organs. It secretes that sebum. It's a product from the sebaceous gland to moisturize and acidify the skin. Our skin actually has a more acidic level. So if we think back to high school and we think about acidic and alkaline range, we want our skin to be on that acidic range. And we'll discuss that, the pH of our skin, in just a little bit. But that helps to protect against bacteria and fungal infections. So we want to help keep that pH of our skin. And next slide. So there's proteins in the dermis itself. And as you see in the graphic here, the collagen is the shape and structural support. So on the graphic here that says aging skin, you see the elastin are those little green molecules there in the picture. And the collagen are the kind of blue, white structures that you see when in the younger skin. There's shape and structural support. The elastin is the ability to retain that shape and structural support, so they work together. But as we age, the elastin and the collagen become loose, and so and not as structurally strong. So there's different things that we can do in our skincare practices to help that and to retain the collagen and the elastin, and we'll get into that too. And next slide. Now we're into that third layer of the skin, the subcutaneous tissue, which contains the actual fat cells and the connective tissue. The function of the subcutaneous tissue is it assists in regulating body's internal temperature. It connects the skin with bones and muscles. It limits damage to bones or organs from impact or trauma, and store in fat cells. So if we think about limiting damage to bones or organs, we've heard of pressure injuries and wounds from when we're sitting in certain positions, or they can actually produce pressure injuries. And so it limits the damage. It's that extra kind of adipose tissue sometimes that helps protect from those trauma injuries or pressure injuries even. Next slide. Okay, so now we're going to get into some intrinsic or extrinsic factors of the skin. So the intrinsic factors are non-modifiable. We're not able to change the intrinsic factors, such as our age. We can't change that. Pre-existing skin disorders, chronic or acute health conditions. Now, the extrinsic factors of the skin are modifiable, and we can change those, such as fluid, making sure that we're taking in the proper amount of fluid that our physician would recommend for us individually. Our diet, making sure that we're eating the diet that our primary care provider has educated us about, making sure that we're eating well, our lifestyle, and skincare practices. And again, we'll get into some products and things that I've used in practice later in the presentation. Next slide. Okay, so I had discussed earlier, we're going to talk about the pH of the skin. So we're going to do that. The acid mantle is a thin film with a slightly acidic pH on the surface of the skin that provides protection for the skin. It helps to keep moisture in and protects the skin from bacterial, fungal infections, and damage. Factors that can affect the pH of our skin are acne, air pollution, change in the season, humidity levels, we all know about that, certain cosmetics, detergents, sebum, which is the oil of our skin, and skin moisture. Sweat, excessive sun exposure can also affect the pH of our skin. And the goal is we want a more acidic nature of our skin and not alkaline. Some highly acidic skin conditions are, for example, eczema and acne. All right. So now we're going to get into an area that I'm very passionate about, wounds. So we're going to get into the wound healing process. We're going to talk about acute, chronic wounds and what to expect from a healthy wound and what to expect from a wound that's not healthy. So we'll get into that in just a minute. An acute wound is a wound that heals with primary intention or heals by secondary intention, expected to progress through the phases of normal healing. So primary intention is the wound edges are held together by artificial means, such as sutures, staples, tapes, or tissue glue. There is minimal tissue loss and wounds heal with minimal scarring. Most clean surgical wounds and recent traumatic injuries are managed by primary closure. The second stage is delayed primary intention. That's when the wound is infected or requires more thorough intensive cleaning or debridement. And we'll talk about debridement a little bit later, prior to primary closure, and usually 3 to 7 days later. May be used for traumatic wounds or contaminated surgical wounds. And secondary intention, as we discussed here earlier, is spontaneous wound healing. I wanted to define it for you guys. So that's when the wound heals like we want it to. It spontaneously heals on its own through a process of granulation, contraction. So those wound edges are actually contracting inward. That's a healthy wound healing. And epithelialization, so that new tissue begins to form. Results in scar formation and used as a method of healing for pressure injuries, ulcers, or dehisced wounds. A dehisced wound is when a surgical wound opens after it's been closed. So we don't like those dehisced wounds. We try to prevent those, but sometimes they do occur. Now, a chronic wound is a wound that fails to fully heal or respond to treatment over a normal expected healing time frame. A lot of patients will ask, how long is that time frame? So it's about 4 weeks. So after that, that becomes a chronic wound. It becomes stuck in that inflammatory phase. Initially, we see that inflammation. We want that to happen because the oxygen's coming to that area. Our body recognizes that there's a wound. But when that inflammatory phase lasts for a long period of time, that's when we need to do something to get that wound healing and going in the right direction. So this pathologic inflammation is due to a postponed, incomplete, or uncoordinated healing process. Wound healing is delayed by the presence of intrinsic and extrinsic factors. We just discussed those. Some of the other ones are medications. Certain medications can affect wound healing time. Poor nutrition, comorbidities, or inappropriate dressing selection. So those are the dressings that are selected to help heal that wound. If you look on the far side here, there's a graphic that goes through hemostasis, it goes through inflammatory, proliferative, and remodeling. This is the tissue repair and regeneration phases. It involves 3 phases, but the first one we see is hemostasis. It's a process to prevent and stop bleeding. So that our bodies say, oh, there's a wound going on here. Let's kick into action. It's meaning to keep the blood within a damaged blood vessel. It's the first stage of wound healing. Then we go into the inflammation phase, and that's about 0 to 4 days. The body's normal response to the injury. This phase activates what's called vasodilation, leading to increased blood flow, causing heat, redness, pain, swelling, and loss of function of where that wound is located. Wound exudate, and all that big word is drainage. So the drainage coming from the wound itself may be present, and this is also a normal body response. And then we go into the proliferative and reconstruction phase. So our body is starting to repair itself. This is day 2 to 24. That's the time when the wound is healing. The body makes new blood vessels which cover the surface of the wound, and this phase includes reconstruction and epithelialization. The wound will become smaller as it heals and contracts. And then the last phase is remodeling and the maturation phase. And this is about 24 days to 1 year. The final phase of healing. This is when we start to see that new epithelial tissue. It's a little bit paler pink on the outside. we start to see what's called healthy granulation tissue, which is pink and moist. And then scar tissue is formed. The wound is still at risk and should be protected where possible. So now we're going to get into healthy granulation tissue. So we've talked about the acute wounds, the chronic wounds, primary intention, delayed primary intention, secondary intention, and the repair, tissue repair and regeneration. And now we're going to get into healthy granulation tissue. So the healthy granulation tissue, it presents as a pinkish red color. It's moist and it comprises newly formed collagen, as we just talked about, elastin, and capillary networks. That's providing the oxygen and the blood supply that is needed for that wound to heal. The tissue is well vascularized and bleeds easily. A lot of patients will say, oh no, my wound is bleeding. And I say that's always a great sign, because we know that that wound has the potential to heal. And then we just make sure that we're using products that are appropriate for that wound to heal, because every wound causes and structure and so forth is different. So each one we have to treat uniquely. And then epithelialization is another term I've used, and that's basically the process by which the wound surface is covered by new epithelium, so new skin tissue. This begins when the wound has filled with that granulation tissue. The tissue is pink and almost white, and only occurs on top of healthy granulation tissue. All right, next slide. So I wanted to start with some wound healing issues. Some of these terms we're going to get into in a little while, so I wanted to familiarize you guys with these terms prior to us discussing them. The first one is epibole. That's kind of a funny word, but what it means is it's rolled or curled under the closed wound edges. So if you look at this first graphic here, those wound edges, the sides of the wound, they're actually rolled and curled in. These rolled edges may be dry, calloused, or what we call hyperkeratotic, which means a thickening of the epidermis, the outermost layer of the skin. Epibole tends to be lighter in color than the surrounding tissue. It has a raised and rounded appearance and may feel hard and rigid. This also creates a chronic wound, so that those edges that we just talked about that are supposed to contract in to heal, it stalls that process. So sometimes a product is needed, which is called silver nitrate. So we actually open up those edges of the epibole, so that the edges almost go into a wound stage again, so that they can contract in. And to prevent that wound being in that chronic phase of still being open. Undermining, that is caused by erosion under the wound edges themselves, resulting in a large wound with a small opening. And so that graphic right there next to the definition, that shows a picture of undermining, and there's a cotton tip applicator right there. And so it's actually pulling a part of that tissue. So we use a clock face when we're doing this in practice, and we measure it based on the clock, saying that it's from this time to this time, and then we measure the depth of that undermining. Of course, we want that area to fill in, but that is a picture of undermining right there. The next definition that we're going to get into is called tunneling. This is caused by destruction of the fascial planes, which results in a narrow passageway. A lot of times when you think of tunneling, you think of infection. We think of, okay, we got to protect from things that could become like an abscess or drainage that could collect in that tunnel. So we don't like tunnels all that much, and that's one thing that we try to prevent and treat very quickly. Hypergranulation. So you see this, and the picture, the graphic right next to it, you can see it's kind of hard, but there's a tunnel right up straight ahead, and there may be more, but you can tell that there is a connection here between the two wounds, and that picture is showing a tunnel there. And then we'll go on to hypergranulation, and you see the picture in the graphic right next to hypergranulation. We see it's pink tissue and we get excited, but then we see the abundance of that pink tissue. When that skin tries to heal, it's really hard for that new epithelial tissue to go uphill to heal and close. So that can actually stall a wound healing process too. So silver nitrate can be used to help level out that hypergranulated tissue so that it actually will slough off. Slough off just means it will come off in time. And then the edges can actually contract in and not have to go uphill around that, all that tissue. So that's what hypergranulation is. We talked about debridement earlier, so I do want to define that for you and let you know kind of the definition of debridement itself. It's removal of dead or necrotic or infected skin tissue to help a wound heal. And we're going to get into, in just a second here, different types of tissue that stagnate a wound healing. But debridement is the removal of that dead tissue itself. All right. And next slide. All right, so the next slide here, we'll get into some of those definitions. Slough, I had said earlier. Slough is the presence of devitalized yellowish tissue. It's observed and formed by an accumulation of dead cells. So you see in the picture up here on the top, it's there's some maceration, which is the white tissue, and that means that that wound is draining quite a bit. Then there's also that yellow tissue, and that's that presence of slough. So we do, that will need to be debrid, and there's different products we can use for like autolytic debridement, which will remove it without surgical debridement. In certain cases, the slough will have to be surgically removed. Next definition is eschar, and you see there it's a little teeny wound. And sometimes they can be thought of as a, scab, but it's actually eschar. And so that's a dead tissue. So, we would have to take a look at that a little closer. So it's dead tissue that actually sheds or falls off of the skin. Typically it's tan, brown, black, and it may be crusty. And then last is biofilm. Biofilm is formed when certain types of microorganisms adhere to themselves to the wound surface, and a viscous substance is then secreted. And so this is another thing that can stagnate the wound. There's different ways that it can be treated as far as physical removal, sometimes some antibiotic agents can be used. And biofilm is something that's actually, it's still being researched and looked into today, but it is something that causes a chronic wound. All right, next. So now we're going to get into the common types of skin damage. So there's different types. There's mechanical, which we've heard of pressure injuries. There's shear, friction, skin tears, and then vascular. We've heard of venous wounds or venous insufficiency. There's arterial wounds, infectious. Some of the types are candidiasis, herpes, and then getting into chemical, which is incontinence associated dermatitis, intertrigenous dermatitis, or intertrigo is another name for it, and allergic, and burns and diabetic foot ulcers. Next slide, please. So now we're going to get into pressure injuries. And pressure injuries is localized damage to the skin and underlying soft tissue, usually over a bony prominence related to a medical or other device. A pressure injury can present as intact skin or an open ulcer, and may be painful. The injury occurs as a result of intense and or prolonged pressure, or pressure in combination with shear. And we'll get into those definitions here in just a little while of friction and shear. The tolerance of soft tissue for pressure and shear may also be affected by microclimate, nutrition, perfusion, comorbidities, and condition of the soft tissue itself. We talked about microclimate. What is microclimate? Skin microclimate is the term used to describe the interaction between skin temperature and moisture at the skin surface. When the skin is wet, the skin becomes softer and more permeable, and skin pH moves away from its normal acidic range into an alkaline state. And I did want to go over with you guys that in April of 2016, the National Pressure Injury Advisory Panel updated the naming of pressure-related skin issues from pressure ulcer. And since I've been in practice, it's been pressure ulcers. And they changed it to now pressure injury. The reason they changed the definition is to help unify the terminology of intact skin and non-intact skin. Pressure injuries are sometimes referred to as decubitus ulcers, and we sometimes still see that, or bed sores, but this is not proper terminology. Two other pressure injuries that we're not going to get into as in depth as I will with other ones, but I still wanted to mention them, is medical device related pressure injury, which results from the use of devices designed and applied for diagnostic or therapeutic purposes. And the other one is mucosal membrane pressure injury, which is found on the mucous membranes with a history of a medical device in use at the location of the injury. All right, next slide, perfect. Okay, so stage 1 pressure injury. So we see here in that first graphic here where it is red, and then we see in the second graphic slightly swollen with edema, and then pressure injury with darkly pigmented skin. Intact skin with a localized area of non-blanchable erythema, and I'll discuss what blanchable and non-blanchable is in just a second, which may appear differently in darkly pigmented skin. Presence of blanchable erythema or changes in sensation, temperature, or firmness may precede visual changes. Color changes do not include purple or maroon discoloration. These may indicate deep tissue pressure injuries, and we'll get into those in just a little bit here. All right, next slide. On the next slide here, we're going to discuss what blanchable is versus non-blanchable. So blanchable is when I would walk into a patient's room and there's an area that may be at risk, and I'll touch the skin itself. And if it responds and turns white and then turns back red again, that is actually not a pressure injury. That is blanchable. Non-blanchable is when I would touch it and it remains red. At that point, that is a pressure injury. If it's closed, intact skin, that would be a stage 1 at this point. All right, next slide. Stage 2 pressure injury is partial thickness skin loss with exposed dermis. The wound bed is viable, pink or red, moist, and may also present as intact or a ruptured serum-filled blister. I'll hear sometimes, oh, it's just a blister. Well, that's not just a blister. If you're looking at the area, it was hitting an area that they had sat either on. For example, if it was a hip for a long period of time, that is actually a pressure injury stage 2. Adipose fat is not visible at this stage, and deeper tissues are not visible still. Granulation tissue, slough, and eschar are not present. Sometimes that can be confused. Some people think, oh, slough can be still present on that stage 2. Well, that would not be considered a stage 2 at that point. Because granulation tissue, slough, and eschar are not present. These injuries commonly result from adverse microclimate. So we've talked about microclimate and temperature and moisture on the skin, and shear in the skin over the pelvis, and shear in the heel. So for example, if the heels are hitting the end of the bed and have not been elevated to reduce pressure to those heels, or if we're lying in the same position for a long time, either on our sacrum, our pelvis, and I'll actually show you a visual here of areas of our body that we have to be concerned about that could be potential areas for pressure injuries. This stage should not be used to describe moisture-associated skin damage, MASD, including incontinence-associated dermatitis, intertrigenous dermatitis, or medical adhesive related skin injury or traumatic wounds, for example, such as skin tears, burns, or abrasions. All right, next slide. And I'm not sure, I wanted to just say real quick with stage 1, it's non-blanchable erythema of intact skin. So at that stage with the stage 1, it's non-blanchable at that point. All right, so now we're on stage 3 pressure injury, which is full thickness is what we call it, skin loss. So it's in which adipose fat is then visible in the ulcer and granulation tissue. We talked about epibole. So and epibole, rolled wound edges are often present. Slough and or eschar may be visible. The depth of tissue damage varies by anatomical location. Areas of significant adiposity can develop, which adipose is that fat tissue, and it can create deep wounds. Undermining and tunneling may occur. Fascia, which is a slim covering over connected tissue, muscle, tendon, and ligament, cartilage and or bone are not exposed. If slough or eschar obscures, so if it covers the extent of the tissue loss, that would be an unstageable pressure injury, which we'll talk about in a little bit here. All right, next slide. Stage 4 pressure injury is full thickness skin and tissue loss. So with exposed or directly palpable fascia, which is that connective tissue covering, muscle, tendon, ligament, cartilage, or bone in the ulcer, slough and or eschar may be visible. Again, epibole, those rolled edges, undermining and or tunneling often occur at the stage 4 pressure injury. Depth varies by, again, anatomical location. If slough or eschar obscures the extent of tissue loss, again, this is an unstageable pressure injury. All right, next slide. Deep tissue pressure injury. So at this stage, and we commonly will see them on heels of the feet, it is intact or non-intact skin with localized area of persistent non-blanchable deep red, maroon, purple discoloration or epidermal separation, revealing, and as you see here in the graphic, a dark wound bed or blood-filled blister. Pain and temperature change often precedes skin color changes. Discoloration may appear differently in darkly pigmented skin. This injury results from intense and or prolonged pressure and shear forces at the bone-muscle interface. The wound may evolve rapidly to reveal the actual extent of the tissue injury or may resolve without tissue loss. If necrotic tissue, subcutaneous tissue, granulation tissue, fascia, muscle, or other underlying structures are visible, this indicates a full thickness pressure injury. Unstageable stage 3 or stage 4. Do not use DTPI, which is deep tissue pressure injury, to describe vascular, traumatic, neuropathic, or dermatologic conditions. Those are all separate conditions themselves. All right, next slide. So we've talked about unstageable already, so I wanted to define that for you. So as you see in both of these pictures here, the first is dark eschar is actually covering the wound. So at this point, we cannot stage this wound. So we call it unstageable at this point. Sometimes slough can also cover part of the wound and eschar. Sometimes there's a mixture, but is full thickness skin and tissue loss in which the extent of tissue damage within the ulcer cannot be confirmed because it is obscured and covered by slough or eschar. If slough or eschar is removed, so underneath all of that dark necrotic tissue, if that is removed, a stage 3 or 4 pressure injury will be revealed at that point. Stable eschar, which is dry, adherent, intact without erythema or fluctuance. So fluctuance is basically just, it's variable, unstable. It's compressible. So if you touch it, it's actually soft to the touch. On the heel, or ischemic limb should not be softened or removed. All right. So I told you guys earlier that I was going to show you a picture of areas and that are could have pressure, and typically, not always, they are bony prominences. So as you see, the heels, the tailbone, the elbows, the back of the head, and sometimes pressure injuries will be found on the back of patients' heads, especially if they're in ICU or ventilators. So we really try to get those patients turned and repositioned frequently, and have other things like wedges we'll get into, and certain sheets to turn them and keep them off of these bony prominences. As you see in the graphic below, between the ankles, because the two bones, if they're lying like this, they're hitting. So, we can do different things like pillows or wedges in between to keep pressure of those bones off of each other. The outer knees, in between the knees, again, putting a pillow in between the knees, especially for patients that are contracted and they're holding their legs tightly together. We try to put those pillows, hip bones, shoulders, and the ears. We have to be very careful of. All right, next slide here. So shear and friction, we've discussed this all throughout. So to define it, friction is the surface resistance to relative motion as of a body sliding or rolling, and the rubbing of a surface of one body against another. So we think of abrasions, things like that, rug burns, that's a lot of time, that's the friction. Shear incorporates friction and another force. Typically it's gravity leading to pressure injuries, or inertia leading to trauma injuries. And as you see here in the graphic to the side, you see, the friction and the shear from, that internal and external, the forces there working against each other. For prevention of that is proper body mechanics, routine full body skin assessments, and treatment is offloading devices such as wedges and pillows, and also sheets that help prevent the friction and the shear effects. And I'll get into some of those in a little bit here. Barrier creams are also great to use on certain areas that, like the sacrum, where there may be those friction and shear effects. So keeping in mind some barrier creams, and we'll go over some barrier creams in just a little bit. A friction injury will be visible. Friction is the mechanical force exerted when the skin is dragged across a coarse surface, such as bed linens. Simply, it is two surfaces moving across one another. A skin insult caused by friction, we just discussed, looks like an abrasion or a superficial laceration. And then shear is the mechanical force that acts on an area of the skin in a direction parallel to the body's surface. Shear is affected by the amount of pressure exerted, the coefficient of friction between the materials contacting each other, and the extent to which the body makes contact with the support surface, which is the bed. The shear injury will not be seen at skin level because it happens beneath the skin. So those are those pressure injuries that are beneath there. Elevating the head of the bed increases shear injury in the deep tissue and may account for a number of sacral ulcers seen in practice. Next slide. All right, so skin tears. Skin tear is a type of wound that is caused by friction, shear, or blunt trauma resulting in the division of skin layers. If you see in this graphic here, this is a pretty good size skin tear, and it looks as though the tear itself was able to be folded back on top of the wound. And that's typically what we like to do with skin tears. If we can, try to save that flap that has been torn back and roll it back over the wound itself. It helps that skin tear to heal faster. Typically, skin tears heal in 721 days, depending on the depth of the tissue harm. Excuse me. And then we see skin tears in newborns, elderly, with chronic illness and long-term steroid use can increase the risk of skin tears. Now, steroid use can cause thinning of the skin and lower our immune system. So that's why we see skin tears with some patients that have steroid use. All right, next slide. So skin tear prevention, making sure your home is well lit. I know there's different times that the lights may be off and we get up in the middle of the night and might stub a toe and that kind of thing that we've all done, but just making sure that areas are well lit, especially at nighttime. Skin tears are often caused by bumping into your surroundings. Remove any furniture or objects that block a clear path, especially around the bed and on the way to the bathroom. Pad sharp corners of furniture with foam or folded cloth to soften the corners. Remove dressing, so the dressing that you actually put on the skin tear carefully. And we'll get into some techniques for skin tear management in just a minute and different dressings to put on. And then, of course, using a non-adherent dressing so that we don't pull open that skin flap again. All right, next slide. Skin tear treatment. Well, first we want to control the bleeding. May need to apply steady direct pressure, elevate the area for a full 15 minutes. But controlling that bleeding first. We want to gently clean the wound with warm, clean water or sterile normal saline and gently pat dry. As we discussed a moment ago, if a skin flap is still attached, try to replace it by gently rolling the skin back over the wound. Do not cut the skin flap off. Cover the wound with a clean non-stick pad. For example, there's petroleum gauze. It's impregnated actually with petroleum. Just make sure you check your allergies. If you have an allergy to petroleum, you don't want to use that. You want to use probably something of more a silicone type dressing or like a telfa, but just one that's not going to stick or pull that flap back open. Use a stockinette. So if you see in the graphic here, that's a stockinette. It's an elastic net sleeve instead of tape. So if you think about, we're putting tape where there's a skin tear. So then if we remove the tape, it may create another skin tear. So doing something like this will help that area to heal, and then we don't have to worry about creating either more damage to the skin tear that's already there or creating a new one. When removing the dressing, make sure to pull the dressing off in the same direction as the skin flap. So going that direction of the skin flap and not the other direction to open that flap again. All right, next slide. So common types of chemical skin damage. Incontinence-associated dermatitis, IAD, is caused by extended contact with urine or stool on the skin. And if you see here, it's almost like we see sometimes with diaper rash on a child, and we would treat it the same way with putting a layer of either a zinc cream, barrier cream, over the area to keep it protected. But we also want appropriate products underlying. So we'll get into those in just a minute. But with the incontinence-associated dermatitis, it changes the pH of our skin. So we get this type of rash that we try to prevent. Intertrigenous dermatitis, also called intertrigo ITD, is caused by moisture in between the skin folds and the friction itself by rubbing of opposing skin folds. And going back up to IAD, which is extended contact with urine or stool, it's commonly, we'll see it in the groin, the perineum, the labial folds, the vulva, anus, posterior thighs, scrotum, gluteal cleft, and buttocks. IAD is often misguided as a stage 1 or 2 pressure injury. So we just want to make sure we're treating it appropriately and we identify what it is appropriately for us in practice. ITD is commonly, which is the intertrigenous dermatitis, occurs in the axilla, so underneath the arms, under the breasts and the pannus, which is underneath the abdomen, and the groin. All right, next slide. So incontinence-associated dermatitis treatment, we want to use a pH-balanced skin cleanser to protect the acid mantle, which we discussed earlier, of the skin. Use a barrier cream to add moisture back to the skin by using a petroleum-based product for dry skin if you're not allergic to petroleum, and if the area is non-infected. Use a zinc oxide cream, if you're not allergic to zinc oxide, to act as a barrier to protect the skin. Zinc oxide is a little bit of a thicker ointment. So we want to use the zinc oxide cream, and I'll get into some types in just a minute, over those areas that may be a little bit what we call denuded or excoriated, have little wounds, because it'll stick a little bit easier to the skin that has damage to it. You want to use appropriate disposable absorbent pads or briefs, and we'll get into some of those in just a minute. If you suspect that a yeast infection of the skin is present, please consult your primary care physician or specialist. We'll kind of get into what a yeast infection looks like in just a minute, but your physician can offer you either antifungal powders or ointment, but you want to treat that fungal infection, that candidiasis. All right, next slide. And intertrigenous dermatitis, intertrigo, the treatment is pretty much the same. The difference that I want to describe here is you want to discuss with your physician an antimicrobial moisture wicking product. So this is where the sweat in between those folds, and then that creates a rash because of the change in the pH of our skin. So that the moisture wicking fabric, it treats by minimizing friction in between those folds. It fights bacteria. Most of them are impregnated with a silver product in the fabric, and it fights the fungus with that antimicrobial silver in the fabric. So I did want to discuss that with you guys today, that moisture wicking fabrics are available, but consult with your physician. All right, next slide. Infectious skin damage. So that's skin damage that is caused by fungal, bacterial, or viral infections. Infectious skin damage should be diagnosed and treated by medical professionals. These are some examples of infectious skin damage, and I do have pictures on the side here on the right-hand side. The first one is candidiasis, which is yeast infection. As you see here, they have what we call classic satellite lesions. So they're small, kind of raised red whelps, but they look like little satellites. So that would indicate that there's a yeast infection here, and then treatment of some type of antifungal. The next one is herpes gladitorum mat herpes, skin infection, which is caused by the herpes simplex virus type 1, as you see in this second graphic here. And then cellulitis, caused by a deep infection of the skin, such as group A, beta hemolytic streptococcus, strep and streptococcus pneumoniae, strep and streptococcus aureus staph. So when you see like this bottom picture here, typically these patients are admitted in the hospital and on IV antibiotics to best treat this cellulitis. But definitely you want to seek medical attention for a cellulitis for sure. All right, next slide. Allergic skin damage. So hives, urticaria is another name for that, is raised red whelps or patches of skin that often feel itchy and may produce a burning or stinging sensation. It's caused in an allergic reaction. Typically, it fades within 24 hours. The next one is called angioedema, and that is swelling, a swelling of deeper layers of skin. And I apologize for this typo here. It should be angioedema, typically found around the face, and lips and eyes. Most times it's harmless. It clears in 24 hours, but can be life-threatening if the swelling causes the throat or tongue to block the airway. And there's graphics of both on either side there. All right, next slide. And allergic skin damage, contact dermatitis. So irritant contact dermatitis is when a substance damages your skin's outer protective layer. Common irritants include solvents, rubbing alcohol, cleaning products, soaps, shampoos, pesticides, and fertilizers. And then we have allergic dermatitis. So that's when the allergen itself causes an immune reaction of your skin. So common allergens include nickel, medications, formaldehyde, personal care products, plants, and airborne substances. All right, next slide. All right, so now we're going to get into vascular types of skin damage. So I want to discuss the normal function, venous function. So we have competent valves, so valves that are working like they're supposed to. We have physical properties of our venous walls. We have normal function of the calf muscle itself. Normally, there are one-way valves within the leg veins, which help the blood flow in one direction towards the heart. This means blood is traveling against gravity. The calf muscle also helps to move the blood towards the heart. When vein valves are leaky, blood flows backward. We also call that reflux towards the feet. Blood pulls in the lower legs, causing bulging veins at the surface. Symptoms include leg heaviness, leg fatigue, leg pain, ankle swelling, phlebitis, which means inflamed and painful veins, restless legs at night, and night cramps. Venous reflux disease is progressive and worsens over time. Skin changes may also develop, including darkening of the skin around the ankles. The darkening of the skin is sometimes referred to as venous stasis. Skin changes. Eventually, the skin can break down, causing a wound called a venous leg ulcer. And this graphic here on the top is a venous leg ulcer. We'll get into what they are here next. So, and then also some common types of vascular issues are venous and then arterial, which is here in our slide. And we'll discuss those. So venous wounds are the most common type of leg ulcer. They're caused by damage to the veins, and venous ulcers usually form below the knee and on the inner area of the ankle. Venous ulcers are highly exudative, which means a large amount of drainage, and are irregular in shape. As you see in this graphic here above, that's irregular in shape. It's got that maceration, which is basically just a lot of drainage, and it causes the outer area of the wound, the peri-wound, to be white in color. Arterial wounds, which is the wound here below, the graphic below on that outer ankle. It's caused by blocked arteries, are a common cause of the arterial ulcers. Arterial ulcers often form on the outer side of the ankle, as we see above here in that picture. Feet, heels, or toes. Typically small, deep punch lesion and are minimally exudative, so there's not much drainage to these areas. They're pale in color or necrotic wound base with well-defined borders because these wounds have a decrease in blood flow and oxygen to the arterial wounds. Symptoms are ischemic pain, loss of hair on the lower leg, foot and toes, thinning, shiny and taut skin, dry skin with elevation of, or dry skin, and then with elevation of legs. The leg itself can appear pale. With legs hanging down, they turn red and may have pins sensation, cool tip of the extremity, and diminished pulses. I did want to discuss the importance of ankle brachial index. So the ankle brachial index, or ABI, is a simple test that compares the blood pressure in the upper and the lower limbs. A lot of times when it comes to wounds of our legs and we have swelling, We have healthcare providers that would like to apply compression. So compression dressings, they help to support vascular problems, helps with healing of leg ulcers, swelling, or lymphedema by giving compression to the areas that are wrapped. External pressure helps to facilitate circulation and healing. The pressure pushes out the extra fluid from the area to improve blood flow. It is important anytime a healthcare provider wants to apply compression dressings either on you or a loved one, that healthcare provider order what's called an ankle brachial index, because you want to know what the actual blood flow is first before putting compression on your legs. For example, if you do have peripheral arterial disease, there's already some form of constriction of blood flow, and we don't want to constrict that blood flow more by putting on compression. So just make sure that your healthcare provider is ordering that ankle brachial index to see what the blood flow is in your lower extremities prior to applying any kind of compression to your legs. Now we're going to get into burns. With burns, there are thermal burns, which are burns due to external heat sources, which raise skin and tissue temperatures and cause tissue cell damage. There's radiation burns, burns due to extended exposure to the sun or other sources of radiation, such as radiation therapy. And then there's chemical burns, burns caused by strong chemicals coming into contact with skin. And there's also electrical burns, burns from electrical current. I have seen in practice several burns that have been caused by heating blankets. So I just wanted to say, please do not use heating blankets when you're sleepy, or if you're planning on going to sleep or for a long period of time, because burns can be caused from heating blankets. And I have seen quite a few burns caused by heating blankets. All right, so getting into the next slide here, and then breaking down the degrees. So we'll talk today about first degree, second degree, and third degree. So first degree is a superficial burn, as you see in this picture here. So it's that top layer affected only the outer layer of the skin. The location would be red, painful, dry, and with no blister for that first degree. Second degree is partial thickness burn. So it involves the epidermis and part of the dermis layer of the skin, as you see in this graphic here. The burn site would appear red, blistered, and maybe swollen and painful. Third degree is a full thickness burn. Location appears white or charred, no sensation in the area since the nerve endings at this point have been destroyed. And the next slide. So burns affecting about 15 to 20% or more of an adult's body are considered to be major injuries and potentially require hospitalization and extensive rehabilitation. When skin is damaged by a burn, you have a greater risk of infection. Burns can leave permanent scars. Taking good care of burns as it heals may help prevent bad scars. So a minor burn that doesn't require emergency care may involve superficial redness, similar to a sunburn, pain, blisters, an area no larger than 3 inches, about 8 centimeters in diameter. Now we'll get into minor burn treatment. So cool the burn. You want to hold the burn area under cool, not cold, running water, or apply a cool, wet compress until the pain eases. Next is remove rings or other tight items from the burn area. Try to do this quickly and gently before the area swells. Next is you don't want to break blisters. Fluid-filled blisters protect against infection. If a blister breaks, clean the area with water. Mild soap is optional. Apply an antibiotic ointment. Make sure to read complete ingredients and know your topical allergies. But if a rash appears, stop using the ointment. Apply lotion. Once the burn is completely cooled, apply lotion, such as one that contains aloe vera or a moisturizer. This helps prevent drying and provides relief. And then bandage the burn. Cover the burn with a sterile gauze bandage, not fluffy cotton. Wrap it loosely to avoid putting pressure on the burned skin. Bandaging keeps air off the area, reducing pain and protects blistered skin. All right, next slide. And then as we discussed, so burns when to seek medical attention when they're larger than 3 inches, about 8 centimeters in diameter. Burns of any size that cause white or charred skin, burns on the face, hands, arms, feet, legs, or genitals that cause blisters, all chemical and electrical burns. All right, next slide. I did want to get into diabetic foot ulcers because we see them commonly in practice. So diabetic foot ulcers, an open sore or wound that occurs in approximately 15% of patients with diabetes and is commonly located on the bottom of the foot, as you can see in this picture here. Early diagnosis from medical professionals is very, very important to prevent complications. Leading cause of non-traumatic lower extremity amputations in the United States. Risk factors are neuropathy, so loss of feeling in the foot. And I do want to talk about neuropathy a little bit. That's when we can't feel, in our feet, we lose the sensation of feeling in our feet to different extents. So, for example, a patient may have something in their shoe, they didn't know it. It's been rubbing on their foot. Sometimes it can create a wound or end up underneath of their skin and they didn't even know it because they have loss of feeling. Vascular issues, which we just discussed. Foot deformities, so things like bunions or hammer toes. And then wear inappropriate shoes. So podiatry care is very important, especially with the diagnosis of diabetes. I do believe podiatry care is very important to help with those proper shoes and foot inspections, and then uncontrolled blood sugar. All right, next slide. Diabetic foot ulcer prevention, Daily foot inspections. So inspect for things like cuts, bruises, cracks, blisters, redness, ulcers, or objects under the skin. Or any sign of abnormality. Wear appropriate socks and shoes. Obtain or follow up with a primary care physician or specialist on a regular basis to help with recommendations of dietary needs, controlling blood sugar, and treatments if needed. Obtain or follow up with podiatrist for foot health and assessments. All right, next slide. So now we're going to get into infection. So signs and symptoms of infection. If a wound, no matter the type, becomes infected or chronic, it is important to seek medical attention. So signs and symptoms of infection are fever. After surgery, it is common for patients to run a low-grade fever of under 100 degrees Fahrenheit. However, if the fever goes to 101 or above and persists, that can indicate a possible wound infection. Next one, feeling of overall malaise. We just don't feel good. Individuals recovering from surgery or injury should feel better every day. The next one is green, tan, or pungent. It has an odor to it. Drainage. Normally incisions, or wounds drain clear or have slightly yellow exudate. Healthy wound drainage can be managed with dressings or negative pressure therapy, so wound vacs. If the drainage becomes purulent with a pungent or foul odor, it can indicate an infection. Increased pain in the wound. So generally, a patient who is healing well from surgery or an injury should find that their pain is going away. So if it's not going away, there's something going on and is underlying. Redness around the wound. Initially, the wound appears slightly red because of the natural inflammatory process of healing that we discussed earlier, but that redness should gradually decrease in approximately about 5 to 7 days. A deeper redness around the wound that continues to expand and worsen is a sign of wound infection. Swelling of the wounded area, like redness, swelling is normal at the beginning stages of wound healing. However, swelling should be continually decreasing. Persistent swelling could be a further sign of infection or other complications. Warmer skin surrounding the wound, although it can be normal for skin surrounding a wound to feel somewhat warmer when the skin around the incision feels very warm to the touch and doesn't start cooling down. That can indicate that the body is mounting a campaign against an infection. So we have to, look out for those signs. And then loss of function and movement. Another signal of wound infection that may require treatment is when the patient has lost the ability to move the wounded area normally. And real quick, I'm going to get into, I know we're running out of time and I have so much to share with you guys, but I want to discuss incontinence. So with this graphic here, sometimes we feel like in life, we call and ask for help and we were put on hold. It says, hello, incontinence helpline, can you hold? And incontinence is a loss of control of a person's bowels or bladder control, which can cause accidental leakage of body fluids and waste, urine or fecal matter. And it can adversely affect the skin if left in contact. And incontinence is nothing to be ashamed of and should be openly discussed with your healthcare professionals. Healthcare professionals and specialists can provide treatment or products to help treat and provide protection from further complication caused by incontinence. And next slide. Real quick, getting into the products, always discuss these with your primary care physician and check for things that you're allergic to within the individual ingredients. I do not endorse any specific brands or products. However, we'll provide suggestions based on professional experience. So this first line here is Medline Sensicare. Sensicare, there's a moisturizing body cream. So for things like the incontinence-associated dermatitis or intertrigenous dermatitis, this is a good protection to use. And it's Sensicare, I call it the green top, and it actually has a number 2 on it. These can be found online, Amazon, and different medical companies. So you can order them online. The next one is Sensicare Protective Skin Barrier number 3. So when you have those little wounds that have been caused, from incontinence or from, the sweat and the skin folds, this one's a little bit thicker. So where there's some drainage in those areas, this one will stick a little bit better. I call this the red top, but it's Sensicare Protective Skin Barrier number 3. Next slide is Medline. And these lines are very comparable, but I've found in practice that it's always good to have a backup line of skincare or wound care product. And this is another one that's, I recommend, as far as products, this is a good backup skin line. Both of these are good skin lines. But the Medline, there's a Remedy Olivamine NutriShield cream, or it is cream. And it is used for incontinent episodes, protects dried and nuded cracked skin and adds moisture. Then the next one is the Remedy Olivamine Skin Repair Cream. This one I call the purple top, but it is a good just overall lotion for dry skin in general. So this one, the other line didn't have one quite like this, but this one is a good just moisturizing cream. Last one here is the orange top. It is the Remedy Phytoplex Z-Guard Skin Protectant Paste. So this one's going to be that thicker line for those areas. If you have some drainage or some denuded, excoriated areas, this one will stick a little bit better. But of course, always check the individual ingredients to make sure that you're not allergic to any of those. Skincare cleansers. So keeping in mind, anytime we cleanse our face, we're kind of getting rid of that pH balance. So we have to be careful with the actual skin cleansers and moisturizers that we use to maintain that pH balance and acidic nature of our skin. Cetaphil is a good one for a facial cleanser, but it is a face and body pH balance cleanser. This product does need to be rinsed from the skin. Aloe Vesta cleansing foam. So this one is a no rinse bathing, no rinse shampooing, and incontinence cleansing. So if you're out and about, might have had an episode of incontinence and you wanted to clean real quick, this one is a good one to keep in your bag. It's a foaming cleanser, and you can, get from online disposable throwaway cloths, and you can clean yourself quickly with this foaming cleanser. It does not need to be rinsed off. So this one is a wonderful foaming cleanser. And next, and I just wanted to get into some pressure redistribution devices. So we were talking about special sheets. So repositioning sheets to prevent friction and shear. Medline Comfort Glide Sheet is one of them. You can find them online too. There's also positioning wedges. They can be found online also. These are to keep pressure off of certain areas of your body and can to help, to alleviate and offload the pressure on bony prominences. So they are positioning wedges. All right, next slide. These are called body-worn absorbent products. So the goal is for body-worn absorbent products is to wick away moisture from the skin. The first graphic, that we see here, it's a pull-on. It's designed to fit similar to regular underwear. As you see here, there's disposable absorbent briefs designed for easier removal. And there's disposable booster pads and guards designed to provide additional protection in regular underwear pull-ons or briefs. Disposable menstrual pads are not recommended for use in males or in general, as far as, those are meant to wick away certain things and not for the load of like urine. So these products, you want to get the products that are recommended to wick away urine specifically. So disposable absorbent pull-ons, disposable absorbent briefs, disposable booster pads and guards. All right. And then how to help maintain healthy skin. You want to use a moisturizer, lotion or cream on skin. Dry skin can more easily damage. Drink an ample amount of water, helps the skin to be more elastic, but always follow your healthcare professional's orders on the best amount of fluid intake for you. Long sleeve shirts and pants to protect the skin from trauma. Bathing too often can dry skin and weaken the integrity of the skin. Maintain a healthy diet, always following your healthcare professional's orders on the best diet for you, and using products or devices recommended by healthcare professionals or specialists as ordered. All right, I did want to get into the Center for Excellence in Aging and Lifelong Health. We call it SEAL because it's a long name. I am a geriatric assessment nurse, and so I did want to discuss our center with you guys today. Getting to know your SEAL team. It was founded in 2002, based in Williamsburg. It serves the health system and patients throughout Virginia. Our mission statement is to care for others as we would care for those we love, to enhance their well-being and improve their health. Our values: person and caregiver centered care through collaboration, compassion, integration and innovation, education and support. SEAL focus. There's 3 core areas. So the health services research, caregiver programming, education and support, resources for older adults. The second one is services promoting wellness. So geriatric assessment clinic, and that's where I'm a nurse for that. Driving assessment and rehabilitation clinic, we also offer. Caregiver education and support. And then the third core value is community engagement. So caregiver education and support, resources for older adults, resources for partners. Expertise in aging and caregiving. So project management and health services research examines programs and protocols that can be translated into enhanced service delivery and improved health outcomes for older adults, their family caregivers, and professional staff. The Geriatric Assessment Clinic, our interdisciplinary team, comprises an assessment coordinator, counselor, an RN, a geriatrician, a pharmacist who conducts comprehensive medication review, dementia care consultant works with family for 6 months to put plans, in place. And we complete about 250 plus evaluations per year, plus follow-ups. The Jane D. McKinney Driving Rehabilitation Clinic offers both driving assessments and retraining in order to help individuals maintain driving abilities or retire from driving. They complete about 200 plus evaluations per year. All right, that was a long one there. Had a lot to cover, but thank you guys so much. And I feel blessed that I could share with you guys today on a topic that I am so passionate about. Do you guys have any questions? I'd love to answer those.
Our first question is, why do we bruise more as we age?
Why do we bruise more as we age? So that is a very good question. So that can be depending on several different things. Blood thinners, if you're on any blood thinners, that can cause bruising. So take a look at your medications and see what you're taking, if there's any blood thinners. And you may want to discuss that with your healthcare professional. And then making sure too that we're padding areas in our house, that we're looking at our activities and things that we're doing around us, that we're not bumping into our surroundings. And as we discussed too, with the structural support of our skin, as we age, the elastin and the collagen lose that tensile strength. So making sure that we're using things like moisturizers, to keep that pH balance is very important. That's a very good question.
Fingernails turning black and starting to crack horizontally, and small indentations are on all fingernails. What is a possible cause?
That is a very good question. Are they able to hear me? Okay, so you guys can hear me. Good. You want to follow up with your healthcare professional regarding that. There's different types of anemia, and there's different things that can cause that. There's multiple things that can cause that. So I would recommend that you follow up with your primary care physician in regards to that, so that they can take the appropriate labs, visually inspect your nails and see if there's any other areas like on your toes where that's also occurring. But I would either, if you don't have a primary care physician, establish yourself with a primary care physician and let them know about that issue. Very good question.
Do you have any recommendations for dry skin lotion?
Yes, I do. So let me go back here in my slide. Can you see slide numbers? Okay, so go to slide 44. And I'm sorry, I had to go through these quickly to be able to cover all the material, but the Remedy Olivamine Skin Repair Cream, it's the second one here. It's a Medline product. You can go online and buy that. That is a great skin repair cream. So yes, I would suggest the Remedy Olivamine Skin Repair Cream. And that is purple. It protects and relieves damaged skin, such as dryness, cracked, inflamed, reddened, and itchy skin. So that is a good one.
Does the skincare you've been discussing broach the subject of toe fungus?
So toe fungus. So in a way it does, because we did talk about fungal infections. That's another one, as far as I would follow up with a primary care physician. They may want to prescribe something, an antifungal, for treatment. And especially if you've had it for a long period of time, I would definitely see if you can see a primary care physician regarding that, because you would want to treat that sooner than later. And that would be a prescription medication. Good question.
Is there any way to increase skin's elastin and collagen as we age?
Yes, very, very good question. So that is going to be by taking very good care of our skin by drinking the proper amount of water, our diet, making sure that we're eating healthy fruits and vegetables, lean meats, instead of, fried foods. You want to do more grilled or baked items. So making sure diet, exercise is very, very important. So exercising, each day, coming up with a plan of exercise and accomplishing that each day is very important. And then also using a skin moisturizer or lotion. So anytime, my practice is if I wash my hands, I know I'm going to be changing the pH of my skin. So I'm going to then put on a moisturizer right after I wash my hands. And that's also going to help to increase that strength, that tensile strength, and promote, good elastin and collagen, is to keep a good moisturizer for your skin.
What about taking collagen?
Again, I cannot make that recommendation. I would suggest talking to your primary care physician on any kind of supplement, oral supplement. That is important for your physician to know, because they know what medications you're currently on, and if there's going to be any possible interaction. So I would follow up with your primary care provider in regards to any supplements.
All right, and we'll take just one last question.
Okay.
Is it more effective to apply moisture to wet or dry skin?
Yes. So the best time to do that is when you've come out of the shower. So you come out of the shower and just go ahead and, on that moist skin, you want to go ahead and put that lotion on. After you wash your hands, go ahead and put that lotion on. Really, any time that you can get a moisturizer on is going to be great. But I just say when you, come out of the shower, go ahead and get that moisturizer, that good moisturizer on. And that's the way to do it. Awesome.
All right, I don't see any other questions.
All right.
Go ahead and end for today.
Okay. Well, thank you so much. It's been a pleasure. You guys have a wonderful and blessed weekend. And I have enjoyed today. Thank you.